Okay, well, it's nearly
I'll
5 past. Go on.
I'll put the agenda just in. I'll share it in the chat, so we've got that there as well.
Perfect. Okay, well, thank you for coming, everybody. Well, let's make a start. So I can't make a start because something strange has happened to my computer screen. I can't see anything. Never mind, you don't need to, I don't need to be able to say anything. I'm Jenny Drife, I'm the consultant in the START team in South London. I think I know lots and lots of you here, which is lovely, and some I don't know. I think we're too big a group to go around and introduce everybody, but if people are I hope that people will all enter into discussion, so if people could introduce themselves and where they come from at that point, that'd be helpful. But I do want to introduce Sophie, who's done all the work and organisations. Hello, Sophie.
Hello, hi. Hello, hi. I'm the mental health and OT lead with Pathway, so I have been organising this and we'll be sending out some notes and things afterwards as well, so thank you.
And I think everybody knows Alex Bax, our August chair of Pathway. Yes.
Hi, guys. Good to be here.
So we've got just one presenter this morning, and then we're going to have a discussion about the 10-year plan, which I hope we can get lots of discussion going for. But before that, we're delighted to have Lili Lemieux-Cumberlege. I hope I'm saying that right. Lili, are you here?
Yes, it's Lili.
Lili,
yes,
sorry.
I am here.
And I hear that you just finished your PhD and you're on holiday, and nevertheless you're joining us, which is amazing. Thank you so much for doing that. Are you somewhere exotic?
Thank you. I am in Greece, in Rhodes. So
oh, wow.
It is lovely and sunny outside, yes.
I'm sure.
So if I've got like round castle behind me, it's the artwork on the wall.
Well,
yeah, thank you.
Well, I'm glad you managed to get there on the aeroplanes, and I'm very glad that you could make the technology work. So you're going to talk to us about probably the last thing you want to think about on holiday, but psychological masonry flying everywhere and the work-related distress amongst homeless professionals. Is that right?
Yes, that's right.
Yeah. Yes. Over to you.
Okay, I'm going to try and share my slides. I'm currently hotspotting off my phone because invariably my internet shut down as I was attempting to log on. So if you'll give me just a second. Has that come up? Or not yet?
Not yet.
Okay, it looks like it's potentially loading slowly, admittedly.
The joys of technology. Again.
Indeed. Yeah. Right, okay, I think it's coming.
Yeah.
No.
Something's happening.
It came and we lost her entirely, I think.
Oh dear.
I've got the slides as well, so when she comes back.
Oh, well, yeah, so let's come back in. But if you've got them, Sophie, it might be better if you share them here.
I can share them just to save your data.
I think that's probably a good idea,
okay.
Because I suspect that if I try to do that again, it'll boot me out again. So if you're happy to just share the slides.
Let me just try and find them on here, just trying to check what they're called. Okay.
Is it hot in Greece, Lily?
What was that, sorry?
Is it hot in Greece?
Very hot. It's lovely, it's sunny, we haven't had any rain. So, I mean, honestly, I would settle for either hot or no rain, but we've had both. We've had neither of those things, so that's great. So it's good. Yes. Perfect, thank you. And if you're happy to just make them full screen, Sophie, that would work. That way I could just riff off about my notes.
Are they not full screen at the moment?
I guess if you put them into sort of a slideshow mode.
It is in slideshow mode. Let me just see. Is that not working?
Not for me. If so you've got you should have the little button up at the top that says present in Teams.
Yes, hang on. Let me just try that again. Let me try. Sorry, technical difficulties.
No, you're fine. I suppose as a bit of background, so I have just finished my doctorate in clinical psychology at the University of Edinburgh, and as Jenny mentioned, passed my Viva last week with minor corrections, so that was very nice. But this is sort of a project that has been going for a little while, definitely, and that sort of builds on some of my master's research.
Is that working?
No.
No,
Sorry.
I think they're
that's
not.
okay.
They're
We can
visible.
see them.
They're
They're
seeable.
visible. Yeah.
You can see
If
them.
you click enable editing, then you can potentially just collapse the sort of menu on the side, and that will make them a little bit bigger still. But otherwise, I'll just sort of crack on. So
Okay.
this project, I suppose, sort of the important thing to mention is that it's a portfolio thesis that includes a systematic review, mixed method systematic review of PI interventions for staff, specifically in homeless services. And then the second bit was the sort of empirical research that I did on some of the factors, both organizationally and individually, that might increase or decrease people's likelihood to become distressed after workplace events. I've lost the slides. Happy to just keep talking until they come back. It's fine.
Oh, no.
That's okay. And I guess in terms of sort of supervisors, so Dr. Helen Griffiths was the University of Edinburgh supervisor, and Adam Burley, who is, I think, in the call from NHS Lothian, and Emily Path from NHS Lanarkshire were sort of my field supervisors. I suppose if I start off potentially, one of the nice things with this group is that I don't need to give you any of the background about PI. I don't need to give you any of the background about working in homelessness, because you're all really familiar with that. But I suppose one of the things that gets discussed occasionally is that while PI interventions have been are quite loudly supported by people and really encouraged, there is unfortunately sort of a limitation to the amount of evidence that we have behind them that has been sort of conducted in quite a systematic way. And while personally, I think that the anecdotal evidence and sort of results that people are seeing themselves from their services should be more than enough, what we do know is that funders and commissioners like to have the quote unquote hard evidence and the numbers. So I thought it might be quite helpful to do a systematic review of this work. Not sure how we're doing on slides.
Any luck, Sophie? You I think now Sophie's connection is grinding. It seems to be an internet. No. It's an internet morning, isn't it? We're having, isn't that nice?
Yes, it seems like it, doesn't it? Let me see if I can.
Oh, there's something happening.
Oh. I don't know if what's happening is me though. I think that might be me.
No, I think that was Sophie.
Oh,
Sophie's name at the bottom.
Okay,
yeah,
great.
Perfect.
Then I will
no,
stop
it's
presenting.
you.
Now it's you.
We've got you. Yeah, we've got
Okay.
you.
Oh, right. Okay. Well, there's a slide. Excellent.
Oh, you've got the slides. Well, I
think
can't see them,
it's you. Your name's at the bottom, but there's your first slide is up.
The great thing is that I can't see it.
Well, that was slide one. That was your title slide. I've moved you forward to.
Okay.
Go on again.
What I might ask Sophie is if you want to try that again, and I'll just carry on. So I did quite a systematic search of the literature, which involved looking at both the grey literature and the peer-reviewed literature. And by grey literature, I mean things that, haven't been published in academic journals. A lot of those were evaluations from different sites. The Fulfilling Lives project had a huge amount of really great literature and studies that came out of that. And so there was quite a lot of sort of material that came from that. Still not getting anywhere on slides, I don't think, but that's fine. So in total, I had 26 papers that I included after my systematic search. Of those, 7 were peer-reviewed publications, and the remaining 19 were all grey literature. And in total, I had 15 papers that came from the Fulfilling Lives projects. So really significant contribution to the literature. And I suppose that the goal of the systematic review was really to try and sort of synthesize that and bring it together. I had 3 research questions. I feel like I'm in my 5 again. I'm like just going without any prompts.
Go for it. You're doing fabulous. It's fine.
Thank you. So I had 3 research questions. Hey, let's just
Can you
leave
see
it at
them,
that. It's
Lili?
fine.
Yeah.
Yes, yeah, that's fine. If you're just happy to move to the second slide, that'd be great. So 3 research questions. I wanted to see, first of all, the ways in which staff interventions have been implemented with staff and homelessness services, what the impact was of those interventions, both for staff and service users, and then the barriers and facilitators around those interventions. I did look specifically only at staff. Originally, this was going to be a much broader piece of work, and what I found was that it was really getting diluted. And what we do know is that we sort of have a couple of staple staff interventions, it seems like things like supervision, reflective practice, training, communities of practice, team formulation, things like that. So it felt like it would be easier to operationalize interventions when looking just at staff for now. And I also looked only at UK services to sort of, again, try and keep the pool quite specific. If you could move to the next slide, please. So yes, the 26 papers in all. Part of a systematic review is conducting a quality appraisal of the different studies. So of the 7 peer-reviewed publications, 5 were sort of ranked as quite high quality using the mixed methods appraisal tool. 19 grey literature papers, 7 of which were high quality, 6 were medium quality, using this ACOS checklist for grey literature. And I think one of the things that really stood out was that there were some of the evaluations, especially from the Fulfilling Lives project, that were really brilliant, really great pieces of work that I think were probably some of the most important things that I looked at. So it was really nice to see that those sort of documents come out of that. If I could have the next slide, please. So overall, sort of an answer to the first question, how have these approaches been implemented? Staff training was obviously quite a big thing. So 19 of the studies talked about staff training. 11 talked about a specific psychological framework. So we had sort of the Ladder for Life by Ray Middleton, but also DBT, CBT, and cognitive and analytic therapy is obviously quite a big one. So CAT was also used in lots of places. Reflective practice groups were the second most popular intervention. With sort of half of the studies talked about reflective practice groups. And what was interesting was that actually a lot of studies talked about more than one intervention. They weren't just saying we did this one thing and that was it. They really tried to bring in lots of different forms of staff training and support. And in terms of sort of delivery, 5 studies talked about it being delivered by an in-house psychologist versus 9 where it's delivered by an external clinician or professional. If I can have next slide, please. So the second question, potentially the most spicy question, or the one that's most important, was about the impact of implementing PI interventions with staff. And I identified, I guess, 3 categories of impact. So the first one being a restorative impact, so that these sort of settings offer space to reflect on sort of the difficult relationships or processes that happen when you're working in this environment. People talked about supervision or reflective practice as really reviving them, as refreshing or restoring. And a big part of that was receiving sort of validation, reassurance from peers and colleagues. And people really talked about, I think one of the really telling quotes was someone said, you know, I go to supervision, I come out with bucket loads of renewed empathy and compassion for the people I'm working with. So really powerful sort of effects there. There's a formative element as well. So these sort of support settings or interventions offer a chance to link theory to practice and make sense of behavior. Making sense of behavior was something that came up over and over again, so that people could kind of see the bigger picture and they can think about different ways of working that might help them to get around sort of stuckness or stuck points. But also importantly, especially things like reflective practice groups or training sessions help people see where there was already really good practice and building on that, and then identifying if there's other areas for growth and development that might need to be addressed. And ultimately, this has a protective role as well in terms of improving job satisfaction, letting people reflect and feel more resilient, supporting sort of a more positive organizational culture. And several papers talked about feeling like there was a reduction in compassion, fatigue, or burnout or turnover. So there was one that very much said, you know, if it wasn't for these groups, I would definitely have burnt out by now. And in one paper specifically as well, person was sort of talking about having worked with multiple survivors of sexual assault in the last week during lockdown and feeling really sort of thrown and really distressed, sort of out of empathy for the service users she was supporting, and saying without the clinical supervisor I spoke to, I would definitely have had to go off sick. So there is really sort of quite strong suggestions that this can be really beneficial. Can I have the next slide, please? And then in terms of sort of effects for service users, you'll see that I've got in big red letters, association is not causation. And I suppose there were sort of 4 categories of things that came out of there. So one of them is this idea of unhappening. So things that we might previously have expected, like police call outs, like attendance at A&E, exclusion from services. And papers did report sort of an increase in unhappening. So a decrease in those events, which means sort of an increase in unhappenings, essentially. Improved housing outcomes in terms of reduced rough sleeping, more planned move-ons from accommodation, and reduced evictions. The other improved outcomes usually involve looking at things on the outcome star. So for example, improvements in the mental health area of the outcome star or substance use, but also things like people feeling that they had engaged more with mental health services, physical health services, substance use, but also local authority things like social work and housing. And then I've sort of mentioned the quote unquote softer outcomes, which I don't particularly like as a separation, but people talked about things like experiences of relational repair or feeling a new sense of connection with staff or feeling more supported. So all of this got pulled into a model, which is really tiny here. But I suppose what I should stress is that this is a theoretical model, as it says in my notes down there. It's a theoretical model that proposes that sort of PI interventions with staff, by having a restorative effect through sort of those elements I talked about, have both a formative and protective effect as well. So protect staff well-being and also help to develop practice to sort of help people make sense of behaviour and of their experiences. As a result of these more formative effects, people are more confident in working with people with complex needs and are sort of able to provide more continuity of care and continue working with people when before maybe we would have said this person's disengaging, we might have to close the case and just see what happens. And in parallel, the sort of reduced turnover also means greater continuity of care, that people are continuing to get support from key workers that they've got a really lovely relationship with and who they've been able to develop trust with. And as a result of that, what I would propose is that these factors combine to sort of contribute to these improved service user outcomes. I can send around the model because it's very tiny here. Last question was looking at the barriers and facilitators. So I use the EPIS framework for this, which is a framework that is used to look at sort of implementation of pilot projects, especially. So in a preparation phase, one of the issues was there was a lack of buy-in from staff, a lot of apprehension about what this might entail and sort of is this a tick box exercise because it looks good? Or people just saying, you know, actually, I think this might just be the same thing we're already doing, but you've given it a fancy name. Or other people saying, I think this example of, oh God, it's another meeting, was pretty telling. People sort of don't have much time, thinking that it would be potentially a waste of their time. What really helped in contrast was having managers and leaders who were really committed to this and who really bought into it and who were able to communicate that really clearly to the team as well, what the expectations were, what this would involve, what the hopes for this were. In the implementation phase, there was quite a lot of talking about entrenched views and beliefs. So people, yes, I can send the slides around afterwards. So people sort of feeling that there was kind of old thinking of actually, is this going a bit soft on people? Are we no longer asking people to take accountability or be responsible? So sort of a sense of maybe this was a bit of too much of a gently approach. Resource barriers, to no one's surprise, were a huge issue. So people feeling they didn't have the funding to continue these things. They couldn't afford to sort of release staff to go to training because there was no one to run the service if that happened. But in contrast, having really early evidence of change made a huge difference. So especially starting in sites where things were really difficult, were really chaotic, implementing some of these interventions and early on seeing little changes meant that people felt this is worth it. We can see these changes in this service that is really challenging to work in sometimes. And so we can try and roll this out elsewhere. Having a really good facilitator is really important. I don't know if Ray Middleton is on this call, but if you are, people spoke very positively of you. So I think there is really something about people feeling like a facilitator who knows the population they're working with, who isn't just coming in with their cookie cutter training, and who's really able to develop that and adapt it was really helpful. And a financial commitment, unsurprisingly, but also people really liked having multiple forms of support. So potentially having a reflective practice group, but also having smaller supervision groups, or also having their own one-to-one supervision sometimes to sort of bring up things that maybe they didn't feel comfortable bringing up in the reflective practice group. And finally, in terms of sustaining things, funding and commissioning structures, huge challenge to continuing, and sort of difficult to engage with certain stakeholders, so sort of third sector, linking with statutory services, linking with health was sort of quite a challenging thing for some services. But having a really strong commitment to embedding this in sort of organizational culture really helped to counter that. Move to my next slide, please. So in terms of the implications, the great news is that the results really supported the idea that PI can be really effective, that PI interventions with staff can have a significant impact for both staff and service users. Sort of highlighted the importance of really carefully choosing the initial implementation sites and really communicating the rationale and the objectives behind this. And that it would be important to also include service user involvement and co-production, which multiple papers did sort of comment on really clearly. In terms of policy implications, I think one of the things that really stood out was that all the Fulfilling Lives projects obviously had this really long funding cycle. And so they really had the opportunity to do a sort of small pilot, test it out, see how it goes, roll it out to a bigger site, do a bigger evaluation, consider how you shift it for a different site, which was really great and a really nice way of doing that implementation cycle, which you can't really do if you've only got funding for 2 years. It's much harder to do that quickly and to get that momentum. Multiple people suggested embedding PI in commissioning bids really early on. So having commissioners really request to sort of see how people were planning on sort of drawing on PI principles. And I guess one of the bigger questions is whose outcomes do we look at? And what are the outcomes that we think are important and aren't important? And often we look at sort of the hard outcomes of how many people moved on and how many evictions did we avoid and how many improvements in services, but actually probably at the heart of PI obviously is relational processes and reflective practice and sort of the really strong human element of that. And so those sort of softer outcomes, quote unquote, I think are really important to include as well. And then the last thing from a research perspective is that I think I would really encourage people, if designing pilot projects, to really consider an evaluation research framework from the beginning. And to sort of consider how the knowledge will be disseminated. It is an unfortunate thing that there's a bit of a hegemony of sort of published research and peer-reviewed publications. I think what stood out was there was some really excellent research out there, and it was a shame that potentially not many people will read it when people have clearly put a huge amount of work into it. And so thinking about how we sort of disseminate research, pull it together so that other people can benefit from it, I think is something to hold in mind. That's it for the systematic review. I feel like that's been a whistle-stop tour. It'll be a similar whistle-stop tour for the empirical study. I saw there was a question pop up in the chat, and I'll have a look after this. And please hold on to burning questions, and I promise I'll try and get back to them. So the second piece of research was an empirical study on the factors that contribute to sort of the development or maintenance of work-related distress. I had 139 participants who completed all measures. Big thank you to the multiple people who are on this call who helped to distribute the survey. I really appreciated it. I didn't have to chase people very much. I didn't want to chase people too much because COVID was happening. It was pretty intense. This was sort of in the height of the first and second wave. But I really appreciate people sort of encouraging others to complete this. And so I looked at some demographics. I looked at organizational culture, which was measured with a culture of care barometer. I looked at cognitive coping strategies, which is the cognitive emotional regulation questionnaire. So the sort of thought processes that people have when they're faced with a difficult event. I used a trauma exposure count where I asked people to endorse whether they'd experienced these sort of a list of 15 events at any point in their career or in the last 6 months or both. I measured PTSD, and then I used the professional quality of life measure to look at compassion satisfaction, secondary traumatic stress, and burnout. So quite a chunky survey, lots in there, but I think the results sort of are really interesting. So I guess the big headline first off, so out of a list of 15 possible workplace events, in the last 6 months, over a third of participants had responded to an overdose, had experienced the death by suicide of a service user who they worked with closely, had received threats to their life or to the life of people close to them, had experienced a significant breakdown in their relationship with a service user, or had experienced at least 3 of those 15 events listed overall. And in the last 6 months, half of respondents had provided immediate support after a service user self-harmed or attempted suicide. Really intense events to experience. So it's perhaps unsurprising that overall 23.2% of participants met the diagnostic threshold for PTSD. So clinical levels of PTSD symptoms, which I think is pretty, I read the results and sort of looked at them and went, oof, sort of really felt those quite strongly, thinking about my own experiences of having worked in frontline services and how distressed and upset I was after some of these events. I then looked at the relationships between the different variables using some multiple regressions. Won't go into the nitty-gritty, but essentially the 2 significant variables for predicting developing PTSD were trauma exposure, so the amount of trauma that people have been exposed to in the last 6 months, and the use of quote unquote maladaptive coping strategies. And I can imagine Adam is currently raising his eyebrows off screen, and I'll come back to the idea of maladaptive versus adaptive coping strategies. That was the same thing also for secondary traumatic stress. However, for burnout, trauma exposure and use of different coping strategies wasn't significant at all. It didn't predict that at all. Instead, organizational culture and compassion satisfaction were the biggest predictors of whether someone would develop burnout or not, which I think has really interesting implications for what we do with services. And then the next slide, please. So to go into a little bit more information about sort of the maladaptive coping mechanisms, the measure I use looks at 4 subscales for rumination, catastrophizing, self-blame, and other blame. And I did some extra analyses afterwards to sort of have a look and say, well, okay, out of these quote unquote maladaptive coping mechanisms, what are the ones that are actually the most important? And rumination, self-blame came out, which I think is particularly interesting because sure, those are the ways that individuals cope, but actually I think there are really strong implications for service level change as well. If you are completing an incident report after an incident and it says staff member responsible at the top, I have completed one of these incident reports myself, and it says staff member responsible at the top, and you're someone who's already likely to take a lot of blame on yourself and to sort of feel quite guilty about your involvement or lack of involvement, that's probably not going to help. And in terms of things like rumination, one of the things we know is that being able to reflect constructively or sort of really think about the psychological effects of a distressing event afterwards make a huge difference to people sort of reappraising and growing post-traumatically. And if in contrast, the debriefing afterwards is really sort of mulling through every step and what happened and what could have happened differently, and sort of really encourages, I guess, some of this rumination, some of this sort of digging things over and over again, then I also think that's probably something that organizations could look at in their sort of policies for how they respond after difficult incidents. Like the next slide, please. So again, a couple of implications. I think the idea behind psychological masonry flying everywhere is an expression that Adam had used where he was talking about, you know, you go into work on a building site and it is your employer's responsibility to make sure that you've got steel cap boots and that you've got a high vis vest and that you've got your helmet and that you've got the protective gear to sort of keep you safe from the brick that might literally come flying in your head in a construction sort of setting. But then I guess the question is, if we know that these are potential occupational hazards from working with people who are highly distressed, who are coping with their distress the best way they possibly can, do we then consider trauma exposure to be an occupational hazard? And then what is the metaphorical hard hat and high vis vest and steel toe boots that we provide staff with to keep them safe? As opposed to saying something terrible's happened and you've had a really difficult experience, why weren't you wearing your helmet if the helmet was never provided? So organizational culture is pretty key overall. And I think one of the things that really stands out is that we have to combine organizational individual interventions. So you might say we need to support individual staff members after they've been through a difficult experience, but that doesn't remove the onus from an organisation as well to do that and to really, I suppose, centre staff well-being in the policies they develop, especially the sort of post-critical incident procedures that are followed, how we consider those things. Something I found very interesting was there was a huge difference in turnover in statutory versus third sector services. So in the statutory services, over half of people had been in their job for more than 10 years. In contrast, in the third sector services, I think it was only half of people had been in their job for under 5 years. So really quite significant disparities, people who hadn't been in their job for very long, lots of turnover. I think there's lots of questions about commissioning that goes into that in terms of also mobility across services or within services. That I think I'd really love to look at more. I saw some slight differences in faith-based services versus secular services. So I think there's a lot to be considered around sort of what are the organizational culture features that are particularly valuable. And finally, I think in terms of future research, I'd really like to look at the type of events specifically that seem to be most significant and the frequency of exposure. And I think within the type of events, I didn't have a big enough sample to contrast different events, different index sort of trauma events, but anecdotally, there were 15 people whose index trauma events were either that they received threats to themselves or the lives of people close to them, that they genuinely thought their life was at risk, or that they had a significant breakdown with a manager or a colleague. And those 15 people had the highest PTSD rates out of the entire sample. It's really interesting to me that someone who has said, actually the most traumatic thing I've experienced in the last 6 months was genuinely thinking my life was at risk, versus someone who says the most traumatic experience I've had has been a really significant breakdown with managers or colleagues, have both pitted that as the most traumatic thing that's happened, and that has been borne out in really high levels of PTSD. So I think there's a really strong thing about the relational harm or the relational pain that happens that I think would be really valuable to look at. I also didn't look at whether people already had access to things like supervision or reflective practice. It was something that I measured, but it didn't fit with the analysis. Unfortunately, I couldn't do that analysis at this point. And lastly, I'd be quite keen to look at whether there's an impact if people have had their own experience of trauma before this work. I did have 28% of my sample had lived experience of homelessness, but there was no difference in any of the measures between the people who did and didn't have lived experience. So I would be quite keen to look into that further. If you're happy to just go to the next slide, Sophie. Okay, that's me. If you just ignore those two, we could come back to those if necessary. Yeah, perfect, thank you. So that was a really quick whistle-stop tour of things. I don't know how you would like to do this in terms of Jenny or Sophie, in terms of questions or whatever it might be.
Yeah, well, first of all, thank you very much, Lili. And just like echo, thank you for joining us and sharing your work with us. I'm sure everyone is still boggling a bit from that 23% of people having clinically diagnosable PTSD. I know I am. It really brings it home how distressing the work can be and how difficult.
I ran that analysis 4 times because I was sure I had done something wrong. I went back because I was like, this seems like a really, really high number. But yeah.
Yeah, but it's certainly nice to have that sort of reinforcement that we're not wrong thinking that it is difficult work.
Yeah.
I think maybe the best way to do questions is for people to either write them in the Q&A or to raise their hands, depending on how much they want a bit of the spotlight. And if people have got any reflections, I guess it could be difficult to share sometimes, but if people have got anything they want to share, then please do. So I guess we could start with Barney's question, which was about the systematic review bit of your work. And he said, we're really interested to hear more about how the impact of PI interventions on positive outcomes for service users was isolated from other factors, which is a good question, and also interested in the methodologies for measuring the softer impacts.
Yes, so this is something that I've discussed pretty extensively in my limitations, and I think actually overall it's something that needs to be noted. These are things, again, they're correlation, they're not causation. So I think it was very difficult to disentangle things. I think in a lot of the papers, there was evidence of a lot of different types of good practice that you could assume might lead to better outcomes. So that might be, you know, a PI intervention, but it also included things like having increased funding suddenly, which meant that people could move from a really small pokey building to something much bigger and more airy, which you could say as part of the sort of built environment side of PI. But also sort of, I suppose one of the issues is also considering over COVID as well, the way that sort of housing access has shifted, the sort of, is it a reduction in rough sleeping, or is it that sort of everybody in and an increase in hotel rooms being available, for example? I only included the sort of outcomes for service users that they were mentioned in at least 2 papers to try and at least balance that out a little bit. But I do think it's something that in general, when designing this kind of study, designing an implementation review in particular, it would be really important to have that thought out from the beginning in the methodology. In terms of softer impacts, there's a couple of things that I'm happy to send around that include sort of the measurement of person-centered care that sort of was developed at the University of Edinburgh, but there's various other sort of ways of evaluating the person-centered care or trauma-informed care that have sort of been developed slowly. The 23% is not published anywhere yet. I have intentionally stayed quite vague on figures, except for that one, because I haven't published yet. I'm hoping to, and we'll definitely let people know once that's done. Same thing for the systematic review. Both of them, the systematic review is currently, I think, under review, or has been submitted for review. The empirical study hasn't yet.
Okay, thank you.
I'm glad to see, Nick, that resonates elsewhere as well.
I think, Nick, you had your hand up.
Yeah, thanks. Thanks so much. That was great. It was great to hear from a lot of it was great to hear. One that it's interesting because I hadn't expected the quality of the research to be quite as high as you seem to find it to be with the quality assessment tools. I thought it was sort of still at a fairly low level, so that's great to see. I guess great to have the review together. I know Peter, I think, on the call, he did one review a few years ago, and it's great to see that updated. And the Mental Health Foundation, I think, also did something. So it's great to see this being regularly updated and the quality. Well, I guess I've got one question: is do you see the quality increasing over those reviews? And secondly, do you have a view about the kind of measures being used and the appropriate measures? You rightly raised that question, you know, for whom are the measures? Who effectively owns the data? And this is a really interesting discussion that we're sort of trying to have with commissioners, because the commissioning figures and data, and arguably some of our research data isn't necessarily centered around the people for whom we're working. Did you have a view about the measures, and do you see an increase in the quality of the research?
So I suppose one of the issues with the quality appraisal, I was quite keen to do a formal quality appraisal because it felt like it was important to, as a sort of really firm way of using sort of the standardized tools for that, to try and see what is the quality looking like at the moment. I don't know if the quality is increasing or not. I think what I noticed is that there are a couple of things where people have done a really great piece of work and then have gone, oh, we should write this up somehow and we should put this together. And the issue is that means that the sort of more rigorous stuff around having a clear methodology doesn't really exist because it's done a little bit after the fact. There are a couple of things of evaluations that were much more clearly defined, where there was a research paradigm that was used. I think one of the big things that stood out was that there was a real lack of citations and bibliographies. And I guess that's a bigger question of, again, as a body of research is building, what do you cite? So that also makes sense. And I guess the theoretical underpinnings, I think it feels like PI is something that is really practitioner-based research. Which I think is excellent. I like that a lot better than the sort of, I think practice-based evidence has a huge role to play, and I think is often a more helpful paradigm than evidence-based practice, because actually if you ask somebody who's working in the field what is more important, they will have a much better sense of that. I suppose what did stand out to me is that, so out of the 2 Fulfilling Lives papers that were published, that have been published, both of those were by Sophie Buckley, who works with Anna Tickle, so a clinical psychologist within the service with research experience, and a trainee who, as her declin thesis, worked there, published something coming out of it. So I think there's a real role, I think a responsibility actually from people with the academic and research background to really link in closely and work with people, because I think it's not really fair to ask people who are in a really busy service and who've potentially not had this really rigid research sort of experience to then publish big things. In terms of measures and things like that, I think, again, having a really clear implementation framework where from the beginning you decide how you're going to measure things is really valuable. Schneider, somebody, I don't remember the first name, unfortunately, but someone whose last name is Schneider, had done the groundwork for looking at well-being in this population specifically, and they used a couple of measures. And the paper they published from that was, this is what we're going to do, this is our plan and what we're going to measure, and then they followed on afterwards. Does that make sense? I don't know if that answers it fully.
Yeah, it was really good advice to think about the research as you start, rather than getting overwhelmed by all the clinical things that need to be done. So I think that's something we can all learn from. Sam, did you want to come in? I see you put your question in the chat, but do you want to say?
Yeah, it's just, I mean, it's an obvious point, Lili, but I mean, if we could have that data, it would be really helpful to be able to put in front of managers just to say, well, you know, this is what people are up against. But I mean, in some ways, you'd think it was obvious. And I mean, you know, it's not that staff aren't backwards in coming forwards, actually, about, you know, the burnout, about how it makes them feel, about the trauma and stuff like that and whatever. And we really struggle. Well, I'm really struggling at the moment to get those sites to fund, and it's not much. It's really not a lot of money to be able to support this, to support reflective practice. And I mean, you know, even when I check, it's not like new, is it? It's not new. You know, this has been seen to be sort of core for 20 years, and yet I don't know. So I was just interested in other people's experience of trying to get reflective practice. I mean, it may be for the pathway teams that we are a bit quirky. We don't sort of fit, because we're in a hospital where hospitals don't really think that way. We're not a community service. We're not a PI service or whatever. But I don't know. I'm just interested in other people's experiences of trying to get this kind of support in place.
I guess I would just quickly answer that, though, in terms of being in a hospital. So I work in a psychosis and complex mental health team at the moment, and we have psychologists within the inpatient, the sort of acute inpatient and rehab wards. And it's something that it has been a lot of work to get traction to do reflective practice. And I think, especially when you have got really tight staff, I think it's really difficult to sort of get that going. And I think it's also prioritizing it and saying, actually, this is something that we need to put protected time in. It's something that is a standing commitment. And one of the papers did comment that actually having someone external meant that there was a bit more of a responsibility to put that time aside, because are we going to waste this professional's time who's coming in? It's not a team leader who's running this. It's not someone internal. It's actually someone who is coming from outside to do this. And if they turn up and there's 2 people for a reflective practice and both of those people are team leaders, that is actually wasting that person's time. It's not beneficial. So it sort of pushes that a little bit in a slightly different way. And I know our psychotherapy department in Edinburgh does that, specifically does the reflective practice in various teams, because there is that kind of pressure of, we've got to make good use of this. Acute physical health hospitals. Mostly.
Yeah. Where there is a bit of a culture, there's a bit of a macho culture. I mean,
yeah.
So often you're sort of met with, well, what's that for? And it's just kind of like, isn't that just part of the job? Isn't that just part of the job? That's what they signed up for. And it's kind of like, well, but you want to keep them there, obviously, don't you? You need to invest in your staff. We want them to build their experience and whatever. So yeah, it was just to say, yeah, the quicker we can have that to slap in front, whether it will make a difference, I don't know. It'd be interesting to do research on whether evidence like that makes a difference to whether support gets provided.
Yeah, well, if anyone's on the editorial board of Health and Social Care in the Community, you've heard it. So yeah.
Okay. It's a very good point about external facilitators. I think it's certainly been our experience that you get kind of embarrassed, socially awkward about not turning up if someone's come from outside. Maria Preston had your hand up.
Oh yeah, do we need to do an introduction?
Yes, please.
So my name is Maria Preston. I work as a trauma-informed mental health practitioner. So I'm employed by LYPFT, but I work for Forward Leeds. And I work within the STOT team, so that's Specialist Therapeutic Outreach. And I think it's just kind of mirroring what Sam said, you know, like I've been really surprised coming to this role at the amount of clinical support and things that I've actually been offered. So I was like, oh my God, I get this and I get that. But I'd come from like an inpatient mental health setting. So just before I left, you know, I was involved in a really serious safeguarding incident. Basically, a client who was in a relationship with a staff member. And it was kind of like, oh, well, you're leaving. You know, I mean, and it was kind of like, oh, well, you know, I was really quite, I just think sometimes the focus kind of isn't there. And again, I think it's part of it is, it's a hard thing because part of me doesn't, you know, like I signed up for this role. I didn't expect it to be all lovely and nice and rosy because realistically that wasn't going to happen. But I think it is hard for, yes, it is expected and I do expect it in my role, but I think it's having the support to manage those things that are going to happen. Like I didn't expect everyone to be wonderful because that's just completely unrealistic, isn't it? But I think it's kind of like, yes, we are going into a job where, yes, we know we are probably going to have deaths in services and terrible things happen, but having the support there to actually manage that. And I would say, like, coming into this service, I would think that I've been really quite well supported compared to previous roles where it was just non-existent. You know, it's like you're lucky if you got clinical supervision once a month and we're just kind of left to deal with. And I think it was a given. You know, we had staff come to us that had been traumatized on wards, but it was like, oh well, it is what it is, you know. So I think I think services like this are moving towards that, but I think there's still a long way to go to, you know, kind of managing burnout and everything else, because it's just such a difficult role, especially like, you know, for unqualified and support worker level staff. You know, it's just not acceptable, is it?
I think there's also something about what you are allowed to be traumatized by versus what you're not allowed to be traumatized by. So there are a lot of people who reported verbal abuse as being the thing that stuck the most in their mind, that actually didn't have a correlation with sort of PTSD. So I guess there's a side of, you know, verbal abuse, maybe something that is more normalized. I guess if I think back to my own experiences, I had a bunch of difficult things. But actually being told by someone who I'd worked with for 2 years that they hated me, that I was a waste of their time and space, and that they wish they'd never met me, and could I just F off, it hit me much, much more than some of the sort of more physical incidents that I was nearly involved in. And I was sort of told, well, that's just part of working with people who are distressed. And I was like, well, actually, this is really distressing. This profoundly wounds me on a relational level, because I'm someone who takes great meaning out of, you know, providing care and providing support. And actually, this is a really painful experience to have. But also, I think the sort of difference between PTSD versus burnout, it's a lot more acceptable, I think, to say that you are burnt out than to say that you're traumatized. Saying that you're traumatized has implications for should you be off sick. Is there a fitness to practice issue? Are you okay to continue doing this job? Burnout, well, we're all burnt out because we work in a really difficult, busy environment and we don't have enough money and we don't have enough staff, and suck it up. And I think I wrote a reflexivity statement for this because I've realized I went into this research with an agenda. But part of it was I didn't realize until I had left the job I was in that actually I had a lot of I was burnt out. I had a lot of secondary traumatic stress going, and actually I was traumatized. If I had filled out this measure after leaving my job, I would have scored very highly on all of them. But I would never I would have felt embarrassed to say that I was experiencing a PTSD reaction from my work, because what does that mean about my resilience? What does that mean about me, that I can't hack it, that I can't do this tough stuff? Yeah.
There's lots to think about. So yeah, I'm just thinking, so we'll maybe try to go on to about 11. There's some hands up. I just thought the question from Dave, who's just walked away from the screen, but it was very... Maybe we'll wait till he comes back. Sam, I think your point about the vicarious trauma about working in a system where, as much as you try, you can't get things to happen the way that you know they should be happening is very real for all of us. And did you notice that, Lili? Was it something people commented upon?
I did. I found it mainly in my literature review, actually, and I think there was a big study that was done across sort of multiple countries by Michaela Lenzi, and that sort of said that actually people felt the least burnt out when they worked in an organization where they felt like their values, that their values matched up with the organization's values and priorities. But I think there is a huge moral injury, and I think we talked about this last meeting. Actually, there's a huge moral injury that comes from being someone who really understands a lot of how you move through the world as someone who is a caring professional who tries to support other people, and to not be able to do that work properly, I think does bring on a lot of, I think that secondary traumatic stress, or the sort of feeling, I called it indirect trauma in itself, of not being able to respond to somebody in distress the way that you would usually do and are called to do because of system issues or computer says no, or any number of different things. Peter, I just see your comment about PI in mental health services. I know that there's been an introduction in some secure services, and there is one study that's looked at it in I think in an acute ward potentially, that I can dig up. But yeah.
And I think that relates to Dave's question, doesn't it, about how the 23% of figure is there any evidence from other services? How does that compare with figures in the acute inpatient wards, for example?
So I wouldn't be able to compare directly, but I suppose this is the second time, somebody published literally 4 months before I finished, looking at sort of trauma exposure in homelessness services in Canada. But there is more research on that, I think, in inpatient settings, for example, looking especially at the experiences of nurses. And obviously the experiences that you'll have there are quite different, things like having to do restraints, or having people who are highly distressed, having to forcibly inject somebody with a sedative, for example, or receiving sort of quite high levels of sort of violence, or verbal, whether it's verbal or physical aggression. So I think it's pretty comparable. I think some of the results from acute settings have been higher. 23% was actually lower than it has been in some other studies. But I also used a different measure. I used a longer measure, as opposed to a 6-item screen. So I think there's an importance of replicating these results and sort of having a look again and seeing what happens there.
And there was a question from Harriet. Harriet, are you there? You want to ask yourself? I'll read from you. So Harriet says, an AMP in our team, asking if there were particular PI interventions that were more effective than others in reducing trauma. So what was it that made the difference?
So there weren't. So I suppose this is again where the association does not imply correlation. I would be very reluctant to draw any firm conclusions from the systematic review in terms of this is the best intervention or the first one to do, because there were no numbers. There was no room to do a meta-analysis to compare quantitative outcomes, because generally there weren't very many quantitative outcomes at all. So I think it would be something that needs to be looked at further. And again, it's quite difficult to do that comparison point if you don't have sort of studies that really capture that data as well as possible. Sounds like a very politician answer, but yeah.
Sorry, I couldn't unmute myself in time. I am here.
That's all right.
Thank you for that. That was really, really helpful.
Elaine, can't see your surname. Goodwood's got your hand up.
Hi, yeah, brilliant presentation, discussion. I work as National Lead Nurse for Homeless and Inclusion Health at NHS England. So I suppose one of my roles is around how, from a leadership perspective, we can kind of support systems better and I suppose help to spread and scale where we know things are working. And I suppose having worked frontline as well in many kind of inclusion health services, could really reflect and resonate with some of what you're saying, and worked with, I suppose, within different leadership structures where cultures have been probably very opposite sometimes. And I just wondered your thoughts on, I suppose, how we can, I suppose, point more within the system to where we really think the cultures are supporting the things that we feel enable and all the recommendations you've made, really. I take as well Sam's points around the acute sector, and I suppose how we can try and look at influencing some of that as well. Thinking, obviously, within this is a debate, a conversation around working within the homeless sector, but actually there's a lot to learn from this, isn't there, beyond that and across systems, and particularly as we look at sort of post-traumatic growth, post-pandemic and things like that. So I just wondered what your thoughts were on that, what we could be doing nationally to help support this, really, in some way.
I think I know. I think one of the first things probably is embedding it within commissioning bids. Really,
well, I was going to ask about commissioning actually, because it's interesting hearing again, Sam, your and others' points about what I wondered what some of the barriers were to getting access to supervision. Is it that, you know, it's not funded, it's not commissioned, it's not part of the initial bid, it's not having managed IAP services where, you know, supervision is quite embedded. So where is it that kind of?
So I think in the acute, I mean, they don't have massive.
I interrupted there. Carry on.
I think in the acutes, they don't have massive psychology services. The acute physical hospitals don't have massive psychology services anyway, do they? They might have one or two that are behavioural psychologists that, you know, might consult on people who are more challenging on the wards.
Or very specific sort of diabetes or oncology, but
very specific things. The acute psych liaison don't really see it as their role to support other staff, and they don't get support themselves, to be fair. So there isn't anywhere to land it. I mean, we have at St George's where they are very articulate and have been right from the beginning about the impact of the work on themselves, and they have been, you know, they've been very clear about that. They are now getting support from the staff counselling service. So the staff counselling service have agreed to try and do this, but obviously they've got no expertise in the area. But it will be interesting to see how this plays out. So one is not having the staff, and then secondly, it's if you then say, okay, well, let's see if we can find, you know, can we find some funding to get this out, you know, somebody to come in or online. It's just where the budget line sits. Nobody seems to have a budget for this, and it then goes back to, they start asking questions like, well, you know, our cancer staff don't have this, or you know, it starts to be a bit kind of like, I mean, in the A&E staff in St George's have said, well, our A&E staff don't get it, and that's fair. I mean, I worked in A&E, we didn't get it, and I've still got visions of awful things that happened in A&E now, but they don't get it, do they? And I think so. I don't know, but I will say that some of the things that in pathway teams that I've seen are pretty extreme in terms of that witnessing system failure, and those kind of things do sit with people, I think, because they always think I could have done something about it, and actually they probably couldn't. But
I think the thing that sort
of guilt, isn't it?
Sorry, I think I cut off there. I think one of the things that sort of stood out to me was, and I guess part of my agenda in doing the systematic review is because I know that commissioners want data. They want proof that this is a good thing to spend their money on. And I suppose what I was hoping is that actually there's a lot of really brilliant work out there that would say this is an important thing and this is something that is helpful. So I was sort of hoping to bring it together a little bit more so that it's easier to say, well, actually, we have somebody who's looked at all these things and who says that this could be quite a helpful thing. Could we embed that money in and sort of do that and make it happen? I think there's sort of multiple barriers. I think one of the big things is definitely organizational leadership that is willing to fight for it.
Yeah.
And that is willing to say, actually, this is not a negotiable thing. This is a thing that is essential. It is critical to maintaining staff. There were a couple of papers that did a really good job of saying providing supervision to staff once a month for an hour and a half costs this much for 12 staff over the year. And actually, in contrast, someone being evicted, somebody accessing A&E 6 times, the police need to be called out 4 times, costs this much, and it's a no-brainer. And sort of actually saying, this is what we need to look at. We don't have longer term outcome data. And I think that's also really important, saying maybe we haven't seen a change in a year, but that doesn't mean that actually 5 years from now, when somebody has a tenancy available to them, that maybe they'll be able to live in that tenancy in a very different way than they would if we were to say, right, we've got a flat, here you go. So I think there's something about also trying to capture those longer term outcomes that's really important. I did notice Nick's sort of comment on supervision and what that means. I think I had support and supervision where I worked, and it very much felt like line management. So I think it's, again, making it clear what that actually involves, that it's not necessarily supervision as in, are you doing a good job or a bad job? And I suppose I wonder if that's, again, where someone external who isn't your line manager would be helpful. I think in psychology, we tend to sort of suggest that people's clinical supervisors aren't their line managers wherever possible. And I think Peter made a really great point about PI being a package, not being a tick box thing where you say, right, we've done reflective practice, we've done supervision, and so it's fine. But actually say it's quite difficult to disentangle the effects of the different parts of PI. And I think it's not necessarily helpful to do that either. And people did say it's nice to have more than one thing available to me.
Okay, we do need to move on to the second part eventually, but I know that 2 people have still got their hands up, so if we could just maybe stay another 5 minutes. I love this group in the way everyone ends up wanting to talk. It is wonderful. Maria, your hand's up.
Oh, I think for me, like, it just kind of comes down to like much higher like organisational values, like, and about the things about, you say, like what supervision can cost and how really, you know, it's like an hour and a half a week and this cost. I think it's kind of the ultimate, are we all just viewed as replaceable? Like, if I stopped going to work now, LYPFT would recruit someone to replace me. And I think especially with like unqualified staff, that you are just really seen as replaceable. So if somebody left or staff leave or there's a mass exodus, like the previous trust that I worked in, there were 3 vacant ward manager posts. You know, there were no staff. It was like, and it's like, rather than trying to recruit more staff, why aren't you looking at the wider organisational issues of why literally nobody wants to come and work here? And I think until issues like that are addressed, I think things like the reflective practice, it's a long way away, because we haven't even really addressed really basic things like staff retention, or even been able to recruit to post. Like, being a band 2 support worker on a ward, I have friends that witness suicides as a 19 grand a year support worker. You'd get paid more stacking shelves in Aldi. And I think for me, that's really what it comes down to, that healthcare workers, I don't think we're valued the way that we should be. I think you're just seen as just replaceable. Oh, well, they've left, we'll just get somebody to come and replace them. And I think until things like that are addressed and the kind of work culture as a whole is improved, I think it's just such a long way off to kind of dealing with the issues and making it a more positive, supportive working environment.
Yeah, definitely, very true. And the fact that A&E staff don't get any sort of reflective practice, I think maybe we should lead the way and say that it should be there for all the people in these distressing jobs, rather than that being an argument for us not to get it. We do need to end. I'm really sorry, but yeah, really, absolutely. Barney, I know you've had your hand up for a while, so do you want to come in with a succinct final point or question?
Well,
let Lili enjoy her holiday.
All right, thank you so much. And for everything, I mean, it's really important bit of research. I suppose just the other thing I was going to say about making a case for reflective practice, in the chapter I co-wrote for the Michael Preston Shute book about safeguarding and homelessness, just saying the importance of curiosity, the importance for people to be in a space, to be able to be reflective and not to split and sort of other organisation, and keeps line of communications going. Reflective practice is really important to those processes, and I don't know whether that might be a more an argument which can win commissioners over more than staff welfare, but it's sort of linked, obviously, I suppose. Yeah.
Yeah, I think if I could just say like a final thing to wrap up, Jenny, I think there's a real tension for me between the sort of what commissioners want and the numbers that they want, and the fact that fundamentally working in homelessness is a deeply relational thing. And when you're talking about working with people who are highly distressed, who've been hurt by a system, saying, well, actually, we need to put a number to you for the system to want to work for you, is a really painful thing. And I think that in itself is a really hard thing. I don't want the impact that I have on working with somebody to always be quantified. And I think actually it's the relationship that heals. The relationship is the intervention in and of itself. So I think there is a real tension where we get pulled into the new public management sort of way of saying we need to quantify everything and put a number to it. And it's a really hard tension to hold. So I think I just want to acknowledge how hard it is to sort of say, we know what the important bits of our work are, and that maybe right now they don't have a tangible number effect and return on investment, but longer term, probably the return on the relational investment is much more significant. So I think I just want to recognize that that's such a difficult tension to sort of operate in. I work in a CMHT, we have the same thing. We say, if we have an extra nurse, then we can do more things and we can discharge people and have more throughput. But actually, if we have an extra nurse because 6 people have gone off sick, then what happens to all the patients who don't have the nurse who has known them for 5 years, 10 years, 15 years anymore? And how do they feel? That they feel sort of abandoned or left? And it's not yet the language of commissioners. So I guess it's how we marry that between things. Anyways, thank you very much for listening. I'm still hanging around for the next bit, but I might turn my camera off.
Well, thank you so much. And as someone, I think Peter said, we'll look forward to seeing your slides and to all the publications that will hopefully come out of your research. So I'm sure we'll hear more from you. Thank you. So next we've got a hot topic discussion, which maybe some of this can feed into. Do people want to have a very quick 2-minute comfort break, or do people want to carry on? I'm seeing some nods. Okay, well, I guess if we restart at 15:15, we would have still 45 minutes, probably all right. So shall we do that? But please do come back. Yeah, okay. If people need to step away for 5 minutes, go ahead. No, I haven't. We haven't lost too many people, which is great. So the next bit of this morning is the government has asked us all, well, asked everyone to send in evidence about how best to support people with mental health problems, which is very exciting. We've got a month left to do it. We've got to all fill in the survey by 11:45 on the 7th of July. And obviously, the more of us who do that, the more we can try to influence some policy. And then we can complain if we don't get listened to. But we thought it'd be good to have a discussion about what we're being asked and maybe try to formulate some responses about what's important. So Sophie has brilliantly put some slides together, which I meant to do early this morning and didn't manage to. I'm being told I've got poor network quality, which means shut up, Jenny, I think. And I'll hand over to you, Sophie, if you can share your slides. If not, I can try to do it.
Okay, let me just see. Hopefully it will let me do it.
I'll try to plug in a cable as well.
Is that showing anything? Yet?
Not yet. Oh, something's happening.
It's very small. There we go.
Perfect.
Yes. Okay. Don't know why this one's working and the other one didn't, but sorry, Lili. So just with the call for evidence, I've just done a couple of slides just to kind of get us thinking about it. So there is a little bit of background. They are building a new mental health long-term plan as part of the government's white paper. There's been a 12-week call for evidence. Somewhere it said the 5th of July, so I put that in here just so that we don't miss the 7th of July, which is the online date on there. They want to kind of focus on how local services can work together to prevent mental ill health and supporting the development of a plan to prevent and mitigate the impacts of risks of factors of mental ill health and suicide. There is going to be a separate plan for suicide, but they have also included that in the consultation, and that's to add on to build on the 2012 long-term plan that they had for that. There are 6 key areas for consultation, and these are the first 3, and they all have some sub-questions which I haven't put on here because it's quite detailed, and then these are the next ones. So just going back to the first ones, how can we all promote positive mental health? How can we all prevent the onset of mental health conditions? How can we all intervene earlier when people need support with their mental health? And then how can we improve the quality and effectiveness of treatment for mental health? How can we all support people with mental health conditions to live well? And how can we all improve support for people in crisis? Each one of those has lots of different categories of people that you can comment on, but they have an annex at the end that is for what I would describe as the inclusion health group. So we will just kind of focus on that. There are some other questions that aren't their key questions, but ones around the priority, which are the most important issues. What values and principles should underpin the plan as a whole? How can, let's say, one around kind of looking at implementation of effective mental health plans in local populations, and how can you improve data collection and sharing for the plan? And then I've put a link, I'll send this around just so that you've got the link for how to respond. And just a couple of questions I thought would be quite useful to discuss here. So what are our priorities as a group? Do we want to respond as a group or individually, or do we want to kind of coordinate some collective responses? Because I think that could be quite helpful and powerful if we're kind of reiterating the same issues. So those are just some questions, and I have just put the link in here. So it's a really short presentation, and I think we should just kind of go through some of the questions, and I will take some notes and try and type up something afterwards that then if people want to use, they can, but we can have a discussion about how we might want to disseminate that as well. So I'm just ending the sharing now, hopefully. And I'm aware that we don't have much time. So Jenny, I can leave it to you to kind of lead on asking the questions and sharing the next bit. Has it stopped sharing for you, or is it still sharing?
It's still up there for me.
Okay, sorry, I did press
stop
and sharing. Let me see if I can stop presenting. There we go. There.
So I think at the moment they're going to get 49 responses saying we need reflective practice, which is probably a good thing. The other things we can say. Sophie, you also made a Word document with all the sub-questions, didn't you?
Yes.
Which I mean, it's a bit repetitive, isn't it? They're sort of questions which I don't think should put us off from answering, but I think we need to get to the meat in it. I mean, I don't know, what do people think about whether we do a collective response or go individually? Alex, your hands up.
I mean, just on the tactics, I think the ideal would be both and. So people putting their own responses in, if you can, take the time, please do it and have a go, but also to pull collective responses in as well. And then we might even try and do several, because if we can get something really strong, we might then try and take it around to other allies and get a set of other organizations also to sign up to a kind of common statement if we come out with some really strong positions that we want. So Royal College of Psychiatrists, for example, try and get a collective statement. But the other thing I was going to say is a straight, and then it feels to me there's almost a political statement I think we would also want to make. So even that, how can we all, seems to me is framing mental distress in our population as an individualized personal problem. And we're all being told to get on and look after each other while our state continues to exclude,
demonize,
punish and marginalize people. And this is about part of this is about structural, political, economic inequalities, and those kind of, which needs to be said. Maybe the NHS can't fix some of that, but to some extent we are our services respond to the trauma that society visits on our population.
Very
And
wise,
we know that very unequal societies have far higher rates of diagnosable mental illness than more equal societies, for example. So how can we
in
all...
fairness, they do refer to in their document, like they do acknowledge that. But I think you're right that this how can we all, it's a sort of big society answer, isn't it?
It's kind of
And I
saying,
think I have this slight anxiety that we need to make the case. So the question 4, the quality of effectiveness with treatment, I think is something that certainly I'd like to say quite a lot about. I think some of it might get done, well, sort of watered down, and the surrounding things about less statutory intervention, as you say. Lili, you've got your hand up.
When I was working in older adult service, we filled out the national care consultation that went around, and what we had ended up doing is having like a service response that we all then drew on a little bit to do our own response as well. It's quite helpful, I think, to have like a bit of a template or an overarching message, because I think it could be a bit daunting when you see the blank screen or the sort of blank page. So I know I went through, and then there were a couple of questions where I had a lot to say, so I added in my own perspective for quite a long time. So I wonder if that's sort of both and a bigger statement, and then people then have the chance to draw on that potentially for their own additions might be helpful.
Yeah, I agree. It's very wise.
I think that's right. And if the people reviewing it see lots of the same points being made repeatedly, that also sometimes has weight. So repetition is helpful.
Absolutely. Absolutely. So we need to get on with it, really, don't we? Because there's only a month left now. And so if we're trying to pull a collective response together, and then everyone's got to have time to fill it in before they go on holiday, maybe we need some sort of, I don't know, public comms around it somewhere as well, Alex. So get people filling it in. How do people want to do this? So Dee's got a hand up. Dee with a sick child. So is the sick child going to do a guest star, Dee?
She might. I was just going to agree with you about comms. I think once we have a joint response that we're all happy with, I think Ali makes a very good point about drawing on it for our individual responses. But then I think there's a lot to be said for just promoting this through all the usual channels on Twitter and blogs and so on, because the more kind of profile you can raise around a consultation response, the more it kind of focuses minds. So once we have a response we're all happy with, let's talk about how we can communicate it.
Okay, so how are we going to, so there's a lot of questions, there's 6 questions, so just to, I mean, as I say, I suppose my one that it's all very interesting, the positive mental well-being, onset of mental health conditions, earlier intervention, quality and effectiveness of treatment for mental health. How can we support people to live well? Support people with mental health conditions to live well, and how can we support people in crisis? Are there a couple of those that we want to focus on, or how do people want to do it? No, I don't know whose hands are legacy hands and whose hands are new hands. Sophie, you look like you're going to say something.
I was just going to say, I think the last 3 are probably the ones that we can kind of have a meatier discussion on just now. So they're around, I'm just having another look. How can we improve support for people in crisis? How can we support people with mental health conditions? Or maybe not so much that one, but a 4th one as well, improve the quality and effectiveness of treatment for mental health. Because that kind of comes into access and some of those things as well. But I'm happy to be led by what other people think are the priorities.
Yeah, and I think we also remember for the first 3, we need to remember Alex's point that a lot of it is structural inequality. So presenting the onset, I think there's something to be said there, isn't it, about linking it to more general childhood trauma or childhood poverty that affects a lot of our patients. Dave, your hand is up, I think.
It was just how to use half an hour as effectively as possible. I don't know if you want to go through some of the questions. We could almost do a mini Menti thing in the chat and people could just put down headlines and you might get a consensus of what people think are the most relevant issues from here. I'm just aware that 5th of July, like you say, is not so long away if you're trying to build a consensus. And you could maybe, lead a discussion from what comes up there. Maybe some of it's very obvious and it's very clear what we would say as a group, and there might be other points you wanted to tease out.
Okay, that sounds very wise as well. Thank you. Should we start with question 4 then? Should we start with how to improve quality and effectiveness of treatment for ill health? And people can write things in the chat or put their hands up. I mean, I always think we need more beds. We need easier. I'm obsessed with beds and the lack of beds. Easier. We need shorter waiting lists for mental health care. I just feel like a lot of it comes back to money, and easier ins to the mental health system, and being treated as if you need ongoing treatment, not just being discharged immediately. But I'm sure other people have got things to say. I saw a hand up and I've lost it already. Was it Nick? Was it you?
Yeah, sorry. So as usual, typical psychologist, I make it much more difficult, and I'd say we need to question the quality of the data and the fundamental assumptions around which we think about data. So effectiveness connotes a sort of a form of data, and certain forms of data are privileged at the moment. And it's quite interesting. There's a disconnect between, I perceive, between the way in which the NHS gathers what it thinks is effectiveness data, but actually it's just output data, number of people seen, and the quality and what's privileged data in the peer review literature, which of course is RCTs and the like. There seems to be a bit of an appetite for gathering more qualitative data on mechanisms. So why is something effective, and why is it effective for you? And so I think for me, there would be something in there about what do we mean by effective? How do we measure effective? And maybe questioning the existing assumptions.
Gosh, that good point. It widens things out a bit, isn't it? It's going to be hard to bring everything together. There's a couple of calls in the chat for continuity of care, which I think is maybe particularly important from our client group. And I guess we do need to mention the care for the workers in the system as well here, don't we? The sort of high guidelines we were just thinking about, or interventions. My other hobby horse, as most of you know, is substance misuse, and joined up work between substance misuse and mental health services, which probably comes in this bit as well, doesn't it? So making sure that care is joined up between services and not fragmentalized. Yes, get rid of dual diagnosis. Absolutely, it's so meaningless, isn't it?
And it leads to total fragmentation of care, and ignores the functional relationships between mental health problems and drug and alcohol.
Prices have pulled together some really good evidence from Housing First evaluation showing how dual diagnosis gets in the way of providing good, flexible wraparound support for people, and where Housing First tenancies are falling apart as a result. So it would be worth including some of that in this.
Yeah, Barney's comment, kind, thoughtful responses to inappropriate referrals. That's a good point. I think a lot of referrals don't get given short shrift, don't they? I think it does come back to more capacity in the system, less and beds, I think, partly, and also a happier workforce. And more effective workforce, Nick, absolutely.
Somebody's typing very manically.
I can hear the typing, yes.
Yes.
Waiting on tenterhooks to see what comes up. Is it someone's hand is up? Is that a legacy hand or is that a new hand?
No, sorry, Jenny, it's Maria. My chat isn't working. I don't understand what it's doing. I think one thing that can improve the care is kind of like better long-term support options in the community. You know, in the form of like third sector care packages, supported living. There seems to be a massive lack of provision out there for working age adults and people that need longer support or more intensive support that CMHT and other services can't provide.
Sorry, was that something distracted me by coming up on my screen? Was that about improving the long-term care?
Yeah, kind of like more like third sector and care provision and kind of greater access to long-term support and care packages. I think sometimes there's too much emphasis on people kind of gaining full independence from services, where I think in a lot of instances that's just not possible. And like, especially the clients I work with, a lot of them feasibly would never be able to have an independent tenancy, but it's just the long-term support for people just isn't out there.
Yeah, absolutely. I very much. There seems to be a sort of recovery model, doesn't there, that people are going to get better and discharged and be able to function on their own, and that doesn't really fit with the reality of life for a lot of people we know, so maybe that needs to be mentioned as well. Trauma, yes, absolutely. I mean, I guess that also is going to come up in the answers to the first three bits as well, isn't it? But yeah, someone mentioned updating the Mental Health Act. Is it Graham? Do you want to say anything more?
Hi, yeah, thank you. Graham Dennison, team leader for the Homeless Health Service in Dorset, sunny Dorset. Yeah, I just, for me, as I said, something I battle with on a weekly basis, you know, sometimes between Police 136 and the dynamics of trying to organise a mental health act assessment for somebody who's complex out on the street, hard to engage, hard to find, and how things slip between the net, and I'm going through that right now. And there's loads of other dynamics to it for me, you know. In COVID, obviously, I think there was less people having to attend. I think they needed one section 12 and one doctor, and now it's back to two section 12 doctors and one social worker. It's just, I don't know. For me, it seems like it needs updating, the whole process.
Yeah,
from appealing to reports to everything.
And they are, there's a new white paper, isn't there, on the Mental Health Act? So I don't know. I guess this all ties in with it, doesn't it? It all ties in together. What you were making me think about is social care and the difficulty with. I was thinking that because of AMPS, but you know, there's a different availability of AMPS to come out to do street assessments, isn't there? Which means that you sort of access to services varies from place to place. And then I was thinking about other social care things like Care Act assessments and how that can vary a lot, and that probably needs to be brought in this question as well, doesn't it? That we need to be working together. Dee's asked a question about beds and services generally. There's a size of the gap. I don't know that there's if anyone has a evidence-based answer. In our trust, we often have people waiting for weeks to get a bed. At the moment, it's female beds. Sometimes it's male beds, but sometimes there's 20 people waiting for beds. And so, if you're trying to get someone wants to go into hospital informally, or someone wants to be transferred from prisons, it just takes weeks, and prison transfers particularly take months. So there's a definite shortfall. Lili, you've had your hand up for a while.
Yeah, I suppose one of the things that sort of comes out there is probably considering, I mean, I bang on this drum a lot, but I think considering links to research from early on and sort of, I think, considering that not everything works for everybody. So when we're developing things like the NICE guidelines or answers like this, that actually the answer for how can we all intervene earlier when people need support with their mental health is going to be very different for somebody who is perhaps in district nursing without a specific population that they're working with versus somebody who is in an inpatient ward versus somebody who works in sort of a community mental health team. So I think having something there about sort of recognizing different needs and service provision for different populations is important. And yeah, to bang on this drum, especially when they say, how can we improve the quality and effectiveness? The government needs to support research. the government, if the government is going to say, well, you need to give us evidence for this, then the government needs to give the money to provide the evidence. It's not fair to ask services that are so busy and so stretched to also do high quality RCTs. And also RCTs are not the be all end all, but that's perhaps a different subject. But I think there's something there about actually commissioning, developing an evidence base about what works for whom in what context, of complex interventions for people experiencing distress and mental ill health from a very early stage. And that needs to not be developed by people who've never worked in this field either.
Yeah, so maybe that needs to be part of the response to that question, doesn't it? And as you were saying earlier about things people being researched as it goes along rather than as an afterthought, that is, if you're reformulating mental health services, that's what you want to be arguing for, isn't it? Nick, your hand's up.
Yeah, thanks. I was actually building on that, questioning the notion of beds altogether. A bit radical, but okay, so what function does a ward serve, and can we serve that function in another way? As you were just saying, I don't know, it's not everybody needs all of the functions of a ward, and wards are very expensive. Not everybody needs a psychiatrist, for instance. We know, from the What Works for Whom paper, we know that most of the pharmaceuticals or the pharmacotherapy isn't effective for the people who we're serving. Only sort of two forms really are: opiate replacements and depot antipsychotics. So in some form. So could we question that? We've been thinking with our Houston friends a lot recently about community engaged health, and can we provide, one of the biggest problems I see is that mental health services just aren't serving our population. So we would need to reconfigure it. And there's a very good reasons why that is. If you have to serve the whole population, then it's hard to serve a set of people who don't really use your services according to the assumptions you make about those services. They're in one place and in a hospital, etc., etc. So we would need to think much more about community methods of delivering the same functions that perhaps wards have, or some of the same functions that we know to be effective: sanctuary, person-based care, not necessarily a reliance on pharmacotherapy, not necessarily a reliance on security and locked doors. So if we were to really question it and question the assumptions we make about healthcare, I think we might go in a slightly different way to the way we're going at the moment, and then perhaps asking for more beds, although I understand why that is, we may have a different set of solutions to that.
Thought-provoking. There's probably a combination, isn't there? I mean, I certainly feel like some people just need to, particularly, it's not actually my trust, but a barrister friend was telling me about someone he's working with in prison who's been very unwell for months, and he can't be treated in prison with the lack of mental health act in there. So he does need to be moved, and there's nowhere to move to. And I guess for some of our patients who don't have any home or place to be, they need to be somewhere for any form of therapy to take place. But it's a good point. What is that needs to be a psychiatric beds, and where else might some of them go? There's a combination of things.
So it's question that somewhere.
Yeah. Sam, is your hand up?
Yeah, it was just to. I mean, that's the problem, isn't it? There are, for example, in the outreach, we've seen, lots of people who don't meet the threshold for admission and are left out on the streets and whatever, and it rolls on and it rolls on and it rolls on, and then they do get admitted and they get better. Now, I'm not saying that the hospital was the right place for them to be, but it's exactly that point. If there's nowhere else for someone to come in to get treatment and be stabilised, then what? There just isn't any alternatives, Nick, and that's the concern. But having said that, if we did beds per capita across Europe, you've got to ask why.
I didn't open.
Sorry, is that Bill?
Yeah, so and the people who get access to hospital don't get better because hospital is not the right place. It doesn't offer the right set of solutions for that person.
Yeah, again, lots of questions, isn't there? Is that a problem with the hospital you know, should the hospital be doing something else? There's somewhere that person should rather be. But Sam, I couldn't open the thing that you sent for some reason. What did it show about beds per capita?
It's a right. I'll see if I can send it again. Just for a minute.
I think it's my internet.
We're right down the bottom across
Okay.
Europe.
I
It
thought
might
we
be
would be.
mine.
I thought we would be. Barney, is your hand up?
Yes, sorry, I'm just sort of carrying on with the bed conversation. I mean, and the sort of alternatives. I mean, it's the quality of the inpatient care and the appropriateness. And I feel like a stuck record going back to sort of 15 years ago when we had specific beds at St. Luke's Hospital, which was relatively green for the sort of street homeless population, and sort of the quality of the treatment and the experience for people there was very different than it is in a sort of acute psychiatric provision where most people are very, very unwell, and the quietly unwell entrenched homeless person is going to have a awful time and probably not get any benefit. And so it's just those sorts of issues I think are really remain really relevant.
Really true, and it is the most soul-destroying thing to advocate for an admission and wait for months for it, and then it to be entirely useless and probably counterproductive. Lili, your hands up?
Yeah, I suppose that sort of coming in on that, I guess, before thinking about PI, for example, that actually the care that people receive in a ward and the needs will be different. I guess I recently went to visit a ward to see somebody and overheard a conversation where they were talking about someone. They were like, the thing is, all of her stuff stinks and we need to throw it out and get something new. But that is this woman's stuff. It's her only stuff. And we sort of talked about delousing and about cleaning stuff and things like that. But I think there is a real sadness also that even when there is a bed available, this becomes somebody's only home, only bed that is possible for them to access. And so there's the quite, I think, coercive, and people need to accept care that isn't suitable necessarily, because that's the only way that they can receive any care. So I think I like this idea of a ward that is perhaps more specialised, that is more adapted, that knows that people have different needs, that potentially we have perinatal mental health wards sometimes. You know, we have wards that recognise that people have different needs, and that involves also a specially trained staff team that is quite happy to work with someone who perhaps is smelly, or perhaps somebody whose boots can't come off because it's been so long that they've been on. All of this sort of stuff, and who are prepared and willing to provide that care in a really compassionate way. I think I'm from Canada originally, and we also had sort of more intermediary steps. And I think this is maybe part of what Nick is talking about there needs to be somewhere between services or sort of support, sort of accommodation, or the street, or an inpatient bed in a ward. And I guess that sort of quite supported transitional housing, for example, also means that when people are discharged from hospital, there is care that continues to be provided. I worked in a shelter where we had on the 5th floor, we slept 400 people a night. And on the 5th floor, it was supported accommodation that people could be in for up to 6 months, staff around the clock, and all of whom were very highly trained in everything, including administering medication safely, had a fast track to a social worker, had a fast track to getting people back into a ward if necessary. The psychiatrist would come out and do the visit for all the people on the floor the same day, as opposed to people having to always go to appointments and being lost to follow up. So I think there's something about continuity and middle ground services as well that are less extreme potentially than an admission, that could be hugely re-traumatizing for people. So to summarize that, more alternative services that provide a bridging point between sort of main sort of accommodation and community services and inpatient care. So transitional services that can be a step up in care or a step down in level of care, depending on what the person needs.
That sounds very appealing. I just so I think Dave asked in the chat if there's any services that manage their own beds, and our chief exec once came around and suggested it. Do you remember it, Harriet? And said maybe you should have your own beds and then you could have control over them. And then it was never spoken of again. Maybe we need to reignite that somehow. I don't think there's enough beds to give us our own ones. But it's, yeah, people who do need a longer admission and aren't as acutely or floridly unwell as everybody else on the wards, which can be an unpleasant place to be, do maybe need somewhere else to go. Sarah Sarah, your hand is up.
Yeah, hi. So in fact, it's only a couple of weeks. Can you hear me? I don't know whether my microphone's working.
We can. It's
Oh,
nice
excellent.
to see you as well.
It's a new thing. So yeah, no, I've been wondering again whether we look in Westminster at if it's possible to create kind of an inpatient resource, because one of the challenges is the numbers of people being admitted is really high. There are challenges because currently in Westminster, we've got a lot of challenges with accessing any beds at all. But I think if there were, so you kind of go to the hard work of setting things up, and then there's no actual bed available, kind of where you really need it, where the resource is, and you kind of feel like if there was a way of having a kind of cohorted place that you could actually manage the flow of patients much better, you'd probably be much more like.
Oh, we've lost you, I think, or I have.
You could just manage it so much better, and of course sometimes people do need a slightly longer admission, and obviously the acute services at the moment are managing things alongside a step down process, and you just wonder, well, actually maybe having some identified inpatient beds alongside an identified step down provision for this cohort might really make a big difference. And just the other thing we had tried here was with the intermediate care beds, that ICN, which is it's basically health paid beds. So people don't need any recourse to funds or anything like that. It's just a resource for health that is used for the kind of the GPs at Great Chapel Street to put patients into particular beds. They're all funded. They then get put on an intensive case management kind of caseload, but it's really all for physical health. So when it first started, we managed to squeeze in mental health. For example, if you wanted to start antipsychotic, people are quite reluctant because it's a bit like sedating, and you could do that in that setting. But in fact, we've lost those beds kind of opportunities for mental health, and I think that's a bit of an exclusion that isn't really necessary. But anyway.
Just seems a strange exclusion. I'm just aware we've got 10 minutes left, and we probably need to move the conversation on from psychiatric beds. That is one of my hobby horses. And I was just thinking about social housing or supported accommodation as in the next question on the list. How do we improve people's how can we all support people with mental health conditions to live well? Maybe something we need to say there is about the need for good quality accommodation, and maybe that sort of overlaps with this need for step up and step down beds, but good quality supported housing for people with mental health conditioning seems important. Housing first seems important. But Alex, you've had your hand up, so
yes, it's on that point really, Jenny, because we've been advocating for ages for for what we were calling medical respite, but the specialist intermediate care beds. The arguments we were tending to make were around physical health, particularly around the step down need, but actually, as Sarah said, it's a wider need, and whether we should argue for this kind of more diverse provision, but health led or health budgets being deployed to provide this kind of step down accommodation, which ideally would have a route on into longer term supported accommodation out into. I mean, you could envisage really nice move through to step down to supported accommodation to then you might have housing first, you might have more therapeutic community settings and other diverse provision suitable for different needs, which have been, as people have been stabilised, and that connecting to that point that some people need long-term care and support, don't they? And the services, what we see too often, services withdraw from people when they're deemed to be better, don't they? Which is just when actually people they may need some different kind of support, but you often see people just kind of ejected from services, don't you, at that point?
Absolutely. And then sadly, we see them returning to the streets in the future, and we are back to where we began again, which is very distressing. So I think we're sort of looking at that the fifth question now about supporting people to live well. I mean, obviously it does mention a couple of things here. So people with how to improve physical health for people who live with mental health conditions, and what at a system level to ensure that people do have no wrong door for their coexisting mental health and drug and alcohol issues. There's quite a lot that we can comment on, isn't there? The more you look at it. Does anyone? Sarah, is your hand a new hand or an old hand? I mean, I think in that bit, I would be sort of arguing for joined up services and having everything under one roof, so that people can access physical health and drug support around their substance misuse and mental health together. And
Can I
housing
just
advice.
say, Jenny, when people are commissioning, I think one of the really important things when people are commissioning the homeless pathways is to ensure, particularly for health, that actually that there is, if things are commissioned outside of the main statutory service, that there's something within.
You're breaking up a wee bit for me, Sarah.
Huh?
You broke up a wee bit for me. I don't know if you did for other people, but I heard it's really important in commissioning.
No, when people are commissioning services, it seems to me there's a gap, because when services are commissioned outside of the ordinary statutory provision, then there's a kind of lack of link up. Then you basically get a kind of a set up as an us and them. And I think there's something really important if you're commissioning specialist services, that as part of that commission, that you commission the specialist service to proactively communicate and link up with the statutory service. Would help things.
Yeah, so it doesn't get fragmentalized more, I suppose, isn't it?
Yeah,
which I think it can be the danger, that people say these people will be doing this thing. Sometimes there's some overlap and there's no kind of overview of everything working.
Exactly. That you kind of, so that it's essentially with the new intermediate care networks that the integrated care networks, that the homeless populations and the services provided for them are kind of brought into the statutory provision, you know, like the main services, so that they're not an excluded group, that there's somehow, but it's probably going to need to be, the onus might be within the commissioning intention, that is within the intention of the commissioners, that they require the commission service to make those kind of links.
Yeah, so we need the commissioners to be working together, don't we, and thinking about these things. I'm just reading, Peter, your comment. What is CHT?
Sorry, it's CHT, Community Housing and Therapy. It's the organisation I run nowadays.
Oh, I see.
But the problem is we're funded, or most of our patients and clients are funded by social care, and most homeless people aren't. And a lot of mental health treatment is funded through social care, but not for homeless people. For some reason, they don't go through social care. I remember social services saying, oh, you know, exclude people, not allowing us to use the word care when we were setting up hospital discharge services. One social services department said we couldn't use the word care in case they thought people were eligible for social care. But if there's going to be social provision with treatment, there's got to be social care funding for homeless people.
Yeah, I think the lack of social care input is an enormous problem, and one that we should mention. The lack of joined up work between mental health and social care for our clients is very problematic. Elaine, your hands up.
Yeah, I just wondered on Sarah's point, and linking to Peter's as well, but so as part of working in the health inequalities team at the moment, one of the things I've been looking at is within the core 20+5, the plus element, and how we can ensure that there are bigger levers for ICSs around their responsibilities in relation to plus. Bearing in mind, core 20+5 is named within the new acts and other sort of key drivers. So I think it would be helpful if people feel it's appropriate as part of your feedback to sort of hook some of this into some of those national drivers as well, because for me the plus element should be where the point around Sarah's point about actually inclusion health, homeless health is everybody's business, and this is the vehicle to drive it, and this is the mandate that vehicle gives, if that makes sense. So I'd encourage you kind of feed back into some of the national language as well and strategy.
Yeah, I just read Jeff's comment in the chat as well, which is just awful, about people being sent to a closed homeless advice centre all through COVID, but it does certainly have a ring of inevitability about it. And I just think, Jeff, the point you make about digital exclusion is a really important one as well, because I think there's a danger. It just makes me think it's really important that we all fill in this consultation, because we need to make sure that our clients' voice is heard, because there's a danger that things will move in that direction of, oh, let's make things digital, let's have virtual consultations and so on. And we need to make sure that things remain accessible for everybody. We do work with a particular group. So we are nearly at our time limits, and it is, I'm sure everyone has got lots more to say. I'm just thinking about how best to follow things up. I guess what we need to do is collate some of the, I'm looking at you, Sophie, there you come now, collate some of the discussion and the chat into a document, and then people can, you know, take what they like and leave what they don't, as my yoga teacher says, and add in the bits that they, you know, that they think are important. But it would be good to have some, it would spur people on to send it in if we have some general message. And then because we are short of time and we've got 4 weeks to go, maybe we could utilize the power of Twitter to continue this conversation, and then get some responses on that as well.
I was just going to say, and it would be really useful if anyone has anything that they would like to add, they would like me to kind of put together. I'm going to try and write up some of these points to just email them to me. Yeah, so that I can kind of pull it all together. But it'd be useful just to kind of know right now what is the biggest priority that we should be focusing on, because I guess that would just be yeah, I'm sure there's lots, but that was one of the additional questions that'd be useful for us, because part of my role is also around kind of policy and things around mental health. So it'd be useful because I can use my role as well to be pushing forward some of these things. So keep those coming as well to me.
Maybe we could have a list. Are you on Twitter, Sophie?
No.
I don't know if I've seen you on Twitter. You're not?
No, I'm not. I should get myself on there. I'm a bit of a technophobe when it comes to that kind of thing. But, yeah.
I always go quiet on Twitter, and then when we have these meetings, I'm spurred on to be more active. But Sam, you're on it as LHHM, aren't you? And Pathway's on it. So maybe Pathway is the best person to tweet with it, and I'm on it as Drife Jenny or Jenny Drife. I think I'm the only one, so you'll find me. But maybe we should pose some questions through that Twitter account. Alex, would that be all right? About what people think is the most important things to focus on, and then we could get some more.
Yeah, that'd be good. Interesting.
Keep the conversation going that way, because it'd be good to send out a document with about a couple of weeks left, and then people would have time to fill it in as they want to do it. Does that sound all right with everybody? And if people are Luddites like Sophie and not, we could do it on email as well.
And I'll send round the kind of the extra questions that I put in a Word document that I didn't kind of share, so that you can all have them and don't have to trawl through all of those documents, the online.
Perfect. Yeah, you've summarised it really well. It is a bit of a lengthy document. Even the easy read one is a bit lengthy, but Sophie's made it yet easier to read. We need to round up, so I suppose thank you all so much. The next meeting, is it 3 months away? So it'll be October, is that right? No,
beginning of September.
September, back to school meeting. Yeah, so if anyone has suggestions for topics to cover, or if anyone has anything they'd like to present, then please let us know by any of the aforementioned channels. And just once again, Lili, thank you so much for joining from Greece. It was really, really great of you to come and present. It was very thought-provoking and inspiring, so thank you. And thank you everyone else for your time. It's been a great discussion as always, and have a good summer, everybody, but we'll see you on Twitter.
Thank you.
Thanks. Bye.